Hello, I'm Dr. Sishir Mannava. In today's SVINutes, we will be discussing the basics of Subclavian Steal Syndrome, an important diagnosis and cause of vertebrobasilar insufficiency that can be difficult to recognize. We will cover the primary risk factors, approach to diagnosis, and common medical and surgical therapies available. Subclavian steal refers to a syndrome caused by occlusive disease in the proximal subclavian artery, resulting in a reversal of flow in the ipsilateral vertebral artery. This results in blood being stolen from the cerebral circulation to supply the arm, leading commonly to symptoms of vertebrobasilar insufficiency. In rare cases, this steal phenomenon can even affect the heart, resulting in angina due to coronary circulation supply via an internal mammary graft. Regarding vascular pathophysiology, the concern is related distal perfusion pressure in the vertebral artery, which can decrease as the degree of ipsilateral subclavian artery stenosis increases. Eventually, the perfusion pressure will fall below that offered by the unaffected vertebral artery or collateral anterior circulation and result in flow reversal in the affected vertebral artery. More commonly, the left vertebral artery is affected, possibly due to a more acute angle of origin. Let's talk about risk factors. Atherosclerosis is the most common cause of subclavian artery stenosis. Therefore, patients with vascular risk factors such as uncontrolled hypertension, hyperlipidemia, hyperglycemia, and smoking are at higher risk of developing this disease. However, less common causes should also be considered, such as large vessel granulomatous vasculitis, as seen in Takayasu's arteritis, thoracic outlet syndrome, as seen in those patients with the presence of a cervical rib, and stenosis related to post-surgical repair of the aorta, think repair of aortic dissection or coarctation of the aorta. Importantly, younger patient populations may have subclavian steal related to congenital abnormalities such as right-sided aortic arch with an isolated left subclavian artery or other variations of aortic arch and branch anatomy. Regarding the epidemiology of subclavian steal, exact incidence is unknown. The joint study of extracranial arterial occlusion by Fields et al. Showed a 2.5% incidence in over 6,000 patients studied, with only 5.3% of these patients experiencing neurological symptoms. Let's talk about symptoms. If symptoms are present, arm claudication is the most common complaint. Occasionally, coolness or paresthesias in the arm can also be noted. Upper extremity exercise, by reducing arterial resistance, increases blood flow to the arm and can precipitate lateralizing symptoms of vertebrobasilar insufficiency among persons without sufficient collateral flow. Vertebrobasilar insufficiency presents classically as drop attacks, but can also manifest as dizziness, disequilibrium, ataxia, diplopia, vision change, nystagmus, tinnitus, or even hearing loss, which highlights the importance of a detailed and thorough neurological exam. Remember, chest pain or angina can also be seen in rare causes of coronary subclavian steal phenomenon. Physical examination findings suggestive of a significant subclavian stenosis includes a discrepancy of at least greater than 15 mm mercury in blood pressure readings taken in both upper arms, delayed or decreased amplitude pulses in the affected arm, and or a bruit in the supraclavicular fossa. Rarely, skin changes or narrow blood changes can be seen in the affected arm. In regards to imaging diagnosis, duplex ultrasonography and transcranial Doppler are excellent first-line tests that have the advantage of showing real-time physiology while being portable and non-invasive. Duplex ultrasonography can help to quantify subclavian stenosis and visualize some extracranial segments of the vertebral artery, but can be limited by operator dependency, anatomical issues, and limited visualization. However, duplex ultrasound can inform on the directionality of extracranial vertebral artery segments visualized, and certain waveform patterns can indicate a pre-steal or steal phenomenon. Transcranial Doppler cuff testing can help to assess vertebral artery flow reversal, either spontaneous or induced. To identify those patients at risk of induced flow reversal, a blood pressure cuff is placed on the symptomatic arm, inflated to a pressure significantly above the systolic blood pressure for a few minutes, and during cuff inflation and deflation, the TCD monitors the blood flow velocity in the ipsilateral vertebral artery, looking for a change in the direction from antegrade to retrograde flow. Commonly, the severity of subclavian steal is classified into 3 grades. Grade 1, pre-subclavian steal, Grade 2, intermittent partial steal, as well as Grade 3, which is total steal. When ultrasound studies are abnormal, the addition of magnetic resonance angiography and/or CT angiography are important non-invasive tools that can assist in further grading the degree of subclavian artery stenosis, as well as provide more detailed information regarding aortic arch branching patterns and presence of atherosclerosis in other vessels. Regarding medical management of subclavian steal syndrome, if the stenosis is caused by atherosclerotic disease, patients would benefit from secondary preventative measures to control vascular risk factors, including blood pressure control, smoking cessation, glycemic control, and lifestyle changes. Antiplatelet therapy may be warranted in atherosclerotic causes of subclavian artery stenosis as well. Most cases of subclavian stenosis are asymptomatic, but severe symptomatic cases may require surgical intervention. Conventionally, open bypass surgery had been pursued, with the main approach being prosthetic extra-anatomic bypass grafting from the ipsilateral carotid to the subclavian artery. Additional methods of bypass are also shown here on the slide. With the advent of newer, minimally invasive techniques allowing for endovascular angioplasty and stenting, however, endovascular treatment of subclavian stenosis may be preferred in some patients. Some limitations include total subclavian artery occlusion, precluding cannulation, longer extensive lesions, stent obstruction of vertebral artery origin flow, and bleeding risk with longer-term dual antiplatelet therapy. No randomized trials have compared endovascular versus surgical methods for treatment of subclavian stenosis. Therefore, an individualized patient care approach is best. In conclusion, subclavian Steal syndrome can be a difficult to recognize condition, but with improved recognition and diagnosis, we may be able to prevent more serious complications. Thank you for watching this SVINutes video on the basics of subclavian steal, and stay tuned for more helpful content.